Let's start with a series of revising cardiovascular system for MRCP Part 1 theory exams. So, hypertension. In hypertension, if the patient is a black African Caribbean, then you start with calcium channel blockers and then you go to ARBs. No ACE inhibitors is involved in the treatment for such patients. Stage 1 blood pressure is more than 140 by 90. In ambulatory blood pressure measurement, it's more than 135 by 80. In less than 80 years, this blood pressure should be involved with organ damage, and then only you will treat such patients. Stage 2 more than 160 by 100 and 150 by 95 on ambulatory. Severe hypertension is when systolic BP is more than 180 and diastolic is more than or equal to 110 millimeter mercury. The salt should be restricted to less than 6 gram per day. Ideally, it should be 3 grams per day. Caffeine should be decreased. Less than 55 or type 2 diabetes mellitus, you start with ARBs or ACE inhibitors. If this is not sufficient, then you can add either calcium channel blocker or a diuretic. If the patient is more than 55 years and there's no type 2 diabetes, or the patient is a black African Caribbean, then you will start with the calcium channel blockers. If this is not sufficient, you will either add an ACE inhibitors for black Caribbeans, or you can add an ACE or ARB for other patients. Or you can give a diuretic along with the calcium channel blockers. If this is still not sufficient, then you will add the remaining drug. Despite treating with 3 drugs, you will check the potassium level. If it is less than or equal to 4.5 millimoles per liter, you will start with low dose spironolactone. You can also start with chlortalidone or indapamide. If it is more than 4.5, then you will add an alpha or a beta blocker. If the BP is not controlled on 4 drugs, then a specialist review is advised. New drug aliskiren is a direct renin inhibitor. Adverse effect is diarrhea. It stops the formation of angiotensin 1 from angiotensin. Nogen. Centrally acting antihypertensive drugs, these are methyldopa. This is used in hypertensive tension with pregnancy. Moxonidine, essential hypertension, so conventional antihypertension. Clonidine, antihypertension, stimulates alpha 2 adrenoreceptors in vasomotor center. Isolated systolic hypertension, this is the treatment for stepwise like you do for hypertension. Similar treatment should be followed. Now we'll see the drugs in cardiovascular system. ACE inhibitors, these inhibit the formation of angiotensin 2 from angiotensin 1. This is activated by ACE inhibitor by phase 1 metabolism in the liver. Side effect, cough, 15% of patients will experience it, and it may occur up to a year after starting the treatment. This is mainly due to increase in the bradykinin levels. The other side effect, which is more often asked in the MRCP Part 1 and Part 2 theory exams, is angioedema and hyperkalemia. The first dose hypertension is most common in patients taking diuretics along with ACE inhibitors. Cautions and contraindications: pregnancy and breastfeeding should avoid ACE inhibitors. Renovascular disease and renal impairment. Aortic stenosis will cause hypertension. Hereditary idiopathic angioedema may be caused due to this. Specialist advice should be taken before starting ACE inhibitors if the potassium level is more than or equal to 5 millimoles per liter. Indication for high dose diuretic therapy. There is more than 80 milligram of furosemide. Increased risk of hypertension will be there. Monitoring urea and electrolytes. Increase in the creatinine up to 30% from baseline, and increase in the potassium up to 5.5 millimoles per liter after 3 months is acceptable in case of ACE inhibitors. Severe renal impairment, bilateral renal artery stenosis, this can be used. This cannot be used. Adenosine, transient heart failure in AV node, A1 receptor agonist in AV node. Now, this will inhibit the adenyl cyclase and decrease the cyclic AMP and cause hyperpolarization. It increases the outward reflux. Adenosine has a very short T half of 8 to 10 seconds, therefore, it has to be given in form of loading dose. This uses of adenosine is to terminate the supraventricular tachycardia. Enhanced by the effect of adenosine is enhanced by dipyridamole, which is an antiplatelet agent. Okay? And it is blocked by thiophylins or aminophylins. So you have to remember DEAR, DEAR. So dipyridamole will enhance adenosine effect and aminophylin will reduce. Avoid in asthmatics because it might cause bronchospasm, transient flushing, enhanced conduction down accessory pathways, and increases the ventricular rate. Adenosine diphosphate receptor inhibitor, clopidogrel, prasugrel, ticagrelor, ticlopidine. All these are the examples, and the mechanism of action has to be remembered for the exam because this is often asked. So, we'll revise adenosine diphosphate receptor inhibitor. ADP receptor inhibitors are clopidogrel, prasugrel, ticagrelor, and ticlopidine. Mechanism: ADP, main platelet activation factor, mediated by G protein coupled receptor P2Y1 and P2Y12. Main target is P2Y12, platelet aggregation, stabilization of platelet plaque. ACE inhibitor ticagrelor and dyspnea. Interactions: clopidogrel PPI and decreases antiplatelet effect. Ticagrelor contraindicated in high risk bleeding, in intracranial hemorrhage, severe liver dysfunction. ठीक है. Interaction: clopidogrel PPI decreases antiplatelet effect. Ticagrelor contraindicated in high risk bleeding, intracranial hemorrhage, and severe liver dysfunction. So again, adenosine diphosphate receptor inhibitors. The most question they ask is main target is what? P2Y12, platelet aggregation, stabilization of platelet plaque. So that is disrupted. ठीक है. Amiodarone. Now this is a class 3 antiarrhythmic agent. It is used for the treatment of atrial, nodal, and ventricular tachycardia. It blocks the potassium channel and inhibits the repolarization. Therefore, it will prolong the AP, action potential. It will also block the sodium channel, and it has got a similar effect as class 1 antiarrhythmic agent. It has got a very long T half, that is 20 to 100 days. So, loading doses are required. Central vein, it might cause thrombophlebitis, and pro-arrhythmia, it will increase the QT interval. P450 inhibitor, it will decrease the metabolism of warfarin. ठीक है. Monitoring of amiodarone is done with the help of thyroid function test because it can cause hypo or hyperthyroidism. Liver function test, urine and electrolytes, chest X-ray treatment. This is to be done in 3 months, and then thyroid function and liver function test every 6 months. Adverse effect: thyroid dysfunction. It might cause hypothyroidism or hyperthyroidism, any of it. Corneal deposits, pulmonary fibrosis and pneumonitis, liver fibrosis and hepatitis, peripheral neuropathy, myopathy, photosensitivity, slate gray appearance, thrombophlebitis and injection site reactions, bradycardia, increase in the QT interval. I will just revise the adverse effect of amiodarone, which is very important. Thyroid dysfunction, hypo or hyper, corneal deposit, pulmonary fibrosis, pneumonitis, liver fibrosis, hepatitis, neuropathy, peripheral neuropathy and myopathy, photosensitivity, slate gray appearance, thrombophlebitis, bradycardia, and increased prolonged QT interval. Now we'll see angiotensin 2 receptor blocker. Now this will block angiotensin 2 at A1 receptors. And the side effects are hypotension and hyperkalemia, similar to ACE inhibitors. And losartan decreases the cardiovascular accident and mortality in hypertension patient, and ischemic heart disease mortality in hypertension patient. This is one point which is asked in one of the MCQs. Antiplatelets, very important. Acute coronary syndrome, first line will be aspirin, which is to be taken lifelong. Ticagrelor is 12 months. Second line is contraindicated, and clopidogrel should be taken. Aspirin is contraindicated if contraindicated. You can use clopidogrel for lifelong. Percutaneous coronary intervention, first line will be aspirin lifelong, then prasugrel or ticagrelor for 12 months with second line, if aspirin is contraindicated, clopidogrel lifelong. Transient ischemic attack, clopidogrel is given lifelong, and as if this is not sufficient, then you will give aspirin lifelong and diparacetamol lifelong. Ischemic stroke, it's the similar thing. Peripheral arterial disease, again clopidogrel and aspirin lifelong. So transient ischemic attack, ischemic stroke, and peripheral arterial disease. These are related to all other than heart. So clopidogrel will be the first choice in this case, and aspirin will be the second choice. And lifelong treatment is there for all. ACS and PCI, aspirin will be the first line and clopidogrel will be the second line. Along with aspirin, ticagrelor or prasugrel should be given at least for 12 months. Atropine, this is an antagonist of the muscarinic acetylcholine receptor. The uses are symptomatic bradycardia. IV atropine is given as first line for bradycardia, and the treatment for OP poisoning, organophosphate poisoning. They're no longer routinely used in the tertiary care units. Tachycardia and mydriasis are the common side effect. Beta blockers inhibit indications are angina, post myocardial infarction, heart failure, arrhythmias, rate control, drug of choice in atrial fibrillation, hypertension, thyrotoxicosis, migraine prophylaxis, and anxiety. The more important are the side effects. Side effects are bronchospasm, cold peripheries, fatigue, sleep disturbance, then erectile dysfunction. Contraindicated in unconscious heart failure patient, asthma, uncontrolled heart failure, asthma, sick sinus syndrome, verapamil. Use may precipitate severe bradycardia. So this is very important. Uncontrollable heart failure, beta blocker is contraindicated. Asthma, sick sinus syndrome, verapamil. These four are the contraindication. These are the side effects. One more drug is bivalirudin. It is a reversible direct thrombin inhibitor. Dabigatran is an oral anticoagulant. It is again a direct thrombin inhibitor and it doesn't require monitoring. What are the indications? So this is important. Prophylaxis for venous thromboembolism post-surgery. Prevent stroke in patients with non-valvular atrial fibrillation who have more than or equal to 1 risk factors with previous stroke, transient ischemic attack, and systemic emboli. Left ventricular ejection fraction less than 40%, NYHA more than or equal to 2, age more than or equal to 75. If the patient is more than or equal to 65, diabetes, coronary artery disease, and hypertension, you will give dabigatran. So this is important. Prophylaxis for post-surgery, prevent stroke in patients with non-valvular AFib who have more than or equal to 1 risk factor such as previous stroke, transient ischemic attack, systemic emboli, left ventricular ejection fraction less than 40%, NYHA more than or equal to 2, age more than or equal to 75, more than or equal to 65 with diabetes, coronary artery disease, and hypertension.